Good evening, everyone. My name is Leslie Nelson Bernier, and I have the privilege of serving as the president of the UNC Health Foundation. And it's a real joy to welcome you tonight to our UNC Health Equity conversation. You are in for a huge treat tonight with three wonderfully accomplished physicians and researchers. And so I'm going to be really excited to introduce you to them in just a second. But before we get started, I just wanted to make mention again of the question and answer feature and the chat feature. They are enabled on this call. So please take a few minutes to ask questions, chat amongst yourself. The presenters can see these questions. I can see these questions. And so we really want this to be an interactive time together. I wanted to also say that tonight's event is sponsored by the UNC Health Foundation, but specifically by our Diversity, Equity, and Inclusion Council. This event tonight was their brainchild, and so I want to make sure we give credit to that. UNC Health is North Carolina's health system, and we're committed to caring for all of the residents of our state. We recognize, however, that not everyone has equal access to care, and this is a reality that leads to disparities in health outcomes. These disparities have been made even particularly more obvious by COVID-19. Pardon me. Tonight, you're going to hear from three of our leaders who are on the front lines of trying to combat these disparities. They are true champions for health equity. You'll hear about their efforts to eliminate barriers to care and use comprehensive research and data-driven approaches with the goal of improving the availability of quality care for traditionally underserved groups. We have three wonderful speakers tonight, and I'm going to introduce them all, and then we're going to take a moment for reflection for each one of them before they get into their remarks. So I'm going to start with Dr. Corbie-Smith. Dr. Giselle Corbie-Smith serves as our Keenan Distinguished Professor of Social Medicine. She's the director of the Center for Health Equity Research, and she's a professor in internal medicine. Dr. Corbie-Smith is a world-renowned expert in drawing communities together, faculty, healthcare providers, everyone into partnership. And this engagement ultimately transforms the way that academic investigators and community members interact while boosting public trust in research. A really fun little known fact about Dr. Corbie-Smith is that she completed her first and only sprint level triathlon at 10 weeks pregnant. And she did this with her 15-year-old child. And so I wanted to make mention of that because that's a huge accomplishment. She's very, very well accomplished, but I thought that was a fun thing to add. Dr. Keisha Gibson is Associate Professor of Medicine and Pediatrics. She's the Department of Medicine's Vice Chair of Diversity and Inclusion, and she's also the Chief of Pediatric Nephrology. She's a diversity and inclusion champion, and she supports community pipelines. Hopefully we'll get a chance to hear a little bit from her tonight about that. She gives talks to various youth groups, leads a health and wellness ministry, and often volunteers with our UNC student groups. This is not going to come as a surprise at all when you see her bright smile, but she was a cheerleader throughout college, and every other year she still goes back to her school and joins in an alumni cheerleading event at homecoming. Of course, they didn't get to do that this year with COVID-19, but no surprise given her bright smile. And then last, but certainly not least, Dr. Kenya McNeal-Trice. Dr. McNeal-Trice has just recently received an incredibly wonderfully deserved promotion, and she is now our Chief Graduate Medical Education Officer. She also serves as the Senior Associate Dean for Graduate Medical Education. She's the Vice Chair of Education in the Department of Pediatrics. She's the Pediatrics Residency Program Coordinator, and she's also a full professor in the Department of Pediatrics. Dr. McNeal-Trice brings together her experiences from Mississippi growing up to Spelman, where she went to college, and Wayne State University, where she went to med school, and now Carolina. She's a guiding force and inspiration for so many of our learners and residents. She often credits the mentors that she's had along the way, but she's served equally as many mentors. She's served as mentors for many other people as well. And probably one of the greatest things about her is that she gets to know people on an individual level. She really wants to know what makes you tick. And Dr. McNeal-Trice was a dancer. And I guess probably still is a dancer, but she danced her way through high school and college. So again, three very, very talented physicians who are going to speak with us tonight. And I'm going to start with Dr. Gibson, and she's just going to give a personal reflection, perhaps on work-life balance or, this unusually challenging time with COVID-19. Dr. Gibson, whatever you'd like to say for a minute or so on personal reflection.
Thank you, Leslie. That was such a gracious introduction. And thank you for all of you for spending this hour. We were just speaking before the webinar, how we're just honored that many of you should be eating dinner with your loved ones, and you've chosen to graciously provide us a little time to speak with you today. You know, as I'm thinking over the last few days, I mean, I think that it's heavy on many of our minds. This has certainly been a sobering milestone that we have reached in this fight against COVID-19, as we think about all the loved ones that have been lost and all the empty chairs that will be at tables throughout the holidays to come. And as I'm thinking about how we get through these tough times, one of the things that sort of brings me up and brings me out is just seeing the resilience of all of us. I took my mother to get her second COVID-19 vaccine last weekend. Very excited about that. And I couldn't help but to really notice the volunteers who were standing out there in the rain, and you could just feel their happiness. You could see their smile. Obviously they're wearing a mask, so you could feel their smile through their mask despite standing out there in the cold rain. And for me, that just really just speaks to the resilience of who we are as a people. And so as we're thinking about these sobering times, I hope that we can find some inspiration in remembering that.
Lovely, thank you, Dr. Gibson. Dr. Corbie-Smith.
Well, I am certainly just honored to be here with my colleagues. It's unfortunately these days it's rare that we get to see each other. We used to see each other a lot more around the halls of McNider and at the beach. Today reminds me that after every storm, there is sunshine. This is a glorious Carolina recruiting day out today. I snuck away, left the back-to-back Zoom meetings a little early and got a chance to walk in that sunshine. And I think that that's the reflection that I have for today, is that even in the midst of these trials, this horrific benchmark that we've crossed, sorry, you can see that I am actually home. And even with this horrific benchmark that we've crossed, that there, just as Keisha says, there's a tenacity, a resilience, and the beauty of sort of the human spirit that has sort of revealed itself in the midst of this tragedy. And my hope is that this time next year, we'll actually be able to be together and to be able to celebrate that milestone.
Thank you, Dr. Corbie-Smith. And Dr. McNeal-Trice, I'm going to ask you to provide a reflection, and then I'll let you go ahead and start with your remarks first.
Thank you, Leslie. I am again incredibly honored to share this platform with these two incredible women. I was going to merge my reflection and comments, but and had planned words, but I can tell you, just seeing their faces, my reflection is honestly when I first met them here at UNC. Keisha Gibson, I first met when I was a chief resident, and I remember calling a consult and she answered the consult. And I remember thinking, I don't know a Keisha. We have a Keisha. And she was a fellow in our pediatric nephrology fellowship program. And I was so excited meeting her and getting to know her. And I'm just incredibly honored that we are still together as colleagues. And Dr. Corbie-Smith, I don't know if she remembers, but when I first came back to UNC as a faculty member, she hosted a book reading at the Carolina Inn on faculty of color achieving tenure. I don't know if you remember that. And that was my first time meeting her. And I remember being in awe. And I still remember the comments and the advice that she gave about being a faculty member. And I still follow it to this day, like even with how I design my office and my back to the door and how you respond to email. Like I remember her saying this in my head, and that was, wow, like over 13 years ago. And so, you know, that's my reflection, just brief reflection this morning of sharing this platform with two incredible faculty members and women who I consider an icons and an inspiration to me, quite honestly. So thank you. I'm going to share my screen because I do have some slides, and I'm going to talk about healthcare equity from the perspective of medical education. That's the focus of my career as a medical educator and an educational administrator. And my reflection and comments kind of goes from a timeline of how I even got to this place in this space within my career and my journey. All right, I think everyone can see my screen here. Perfect. Let me try to, yes. So with thinking, oftentimes I'm asked, how did I get here to this point in my career? And some people may feel it's purposeful. I don't believe that is the case from my perspective of purposeful, but I know that I truly believe there are not coincidences, and there are people who are placed in our lives and our paths that help us to achieve what it is that we are destined to be. And so, my story for today and talking about this and how I believe it contributes to health equity and breaking down disparities. I just start from the beginning of who I am and where I'm from. I bear my roots in Mississippi. I've been born and raised there. I have the wonderful privilege of both of my parents were born in Mississippi, and our extended family is from there. And that has been wonderful for me. This is a picture of my great-grandparents on my mother's side, Walter and Eveline Lee. And they are huge inspirations for us and icons. I remember my great-grandmother, she passed away when I was 5, and her wisdom throughout our family. Both of my great-grandparents were actually the children of slaves, and they remember that in their young childhood of what that was like, what that time period was like for them, especially after their parents, and especially my great-grandmother, her mother was freed. This is a picture back home. I went back home to visit this summer, and we always go and visit the home of my grandmother and my parents. And this is a picture of the schoolhouse that my grandfather was taught in. You can see it's pretty broken down, but it's on the grounds of the church in the community that sponsored the schoolhouse. And they do their best to keep it from falling to the ground as a remembrance of that. And behind the schoolyard and the church, this is a graveyard or cemetery, and many of my ancestors and family members are buried here. They and have been so for generations, and we have what we call plots and family lines here. And I took pictures of this not only for education of my children. I never thought I would use this in a presentation, but this is just an inkling of how I came to be and where I came from. And these pictures right here are some of the oldest gravestones in my family's graveyard. And you can see that there are dates of birth of 1865 to 1936. This date of birth is 1843 to 1924. So many of these members of my family from generations ago were born into slavery in Mississippi and were freed during their lifetime. The other thing that's pretty noticeable is that while the dates of death here include a month and a day, many of the dates of birth only include a year because there's no documentation of the month or day they were born, and oftentimes there's a guesstimation of the year. This is something we as our family do multiple times to remember where we came from and to know what our inspiration is to do as we go forward in our work. I love this picture. I include this because this is a little bit of a tale for my father. His family, my mother's family, remained in Mississippi, but my father's family, when he was a young boy, moved to Chicago. And this picture, for those who may not know, is a great illustration of what was called the Great Migration. And that is when, during the Jim Crow era, and especially post World War II, millions of Black residents in the South left the South, traveling north, and many ended up in communities in St. Louis, New York, Chicago. Some traveled west to California, but they really were escaping a lot of the the acts and terroristic acts of white supremacy and the Ku Klux Klan. And my father, I didn't learn this until about 2 years ago, his family traveled north after the murder of Emmett Till, who was a young boy around the same age as my father at the time. And that was the time that their family had just had enough. And so I have a wonderful extended family in St. Louis and Chicago as a result of this, but again, is a part of my path and does have an impact on the view that I have, not only for my communities back at home in Mississippi, but also my communities in the Midwest and the North. So going on a little bit with my journey, some of us, you may, based on age, will remember the Wonder Years. I had, a wonderful time growing up and was incredibly loved. I love math and science. I always have, always have. I have had the experience of being tracked into higher advanced courses. I remember in elementary school, that was for me the norm. I used to love that because I felt like it was exciting and challenging and I wasn't bored in school. But I also realized that it was a bit isolating with where I went to school, being tracked into those courses. Oftentimes I was the only person of color. Many times I was the only girl. My birthday is in August and I was oftentimes the youngest student in those courses. And what I often felt like was a fish out of water, but I actually became very comfortable with being a fish out of water, or so I thought. I was able to attend a wonderful magnet school through high school that was exceptional with math and science. And this was really one of my first exposures to women of color who were AP math and science teachers and who served as mentors for me. And one of my favorite accounts is, taking all of my AP biology, chemistry, physics courses, and but being unable to afford to take the AP exam or having to really save and work to take that. And having one of my mentors to this day, who I'll still never forget, Cheryl Goodman, was my AP chemistry teacher and paid for me to take my AP chemistry exam because my family didn't have the money at the time. I don't know if she realized or reflects on what a huge moment that was for me or the impact, but I'm 45 years old right now and I still remember her and her name and how she pulled out her checkbook and wrote that check that day because it was not an option for her that I not take that exam. Going on a little bit with college, I know Leslie already mentioned I attended Spelman College, majored in biology and loved it. Had a wonderful opportunity to study abroad while I was there, and that really expanded my horizons, especially being a young woman from Mississippi. And I met my lifetime mentors there, Drs. Jan Primus and Pamela Gunter-Smith. Pamela Gunter-Smith was my department chair in biology, and Dr. Primus was my biochemistry teacher. Incredibly intelligent women who were at the top of their science grade. And again, this was the first time I'd met PhD scientists who were women of color. And let me tell you, they had an exceptional standard. And it showed me and exposed me to, again, women who could be leaders and women of color who could be leaders in their field. And this picture is Dr. Gunter-Smith, who is now, she is now president of college in Pennsylvania. And I'm just still in awe of all that she's been able to do. I went to medical school at Wayne State and became interested in medicine and pediatrics and continued to have incredible mentorship from faculty and course directors. I loved going to medical school in Detroit, not only because of the rich history in the communities, but being able to experience and have the honor and privilege of practicing medicine in places that had huge health disparities, but also huge community resources and advocates for that. Dr. Wanda Witten-Sherney and Dr. Yvonne Friday were my mentors there. And that was the first time that I again had seen academic medicine, medical faculty who were leading the charge, who looked like me. And Dr. Friday was my clerkship director, and she still is the clerkship director at Wayne State. And who would know that a short 15 years later, that I would enter in the same role that she had. And just seeing her in that role and her inspiration for me going into pediatrics let me know that that was something that I can do. Fast forward to coming here to UNC, I was that person who had never stepped foot across the border until I matched here at UNC. And I was so excited to match into residency here at North Carolina Children's. Excited to serve as a chief resident and then served as a pediatric hospitalist. Dr. Harvey Hamrick was my program director and recruited me to come here. Dr. Julie Byerly was a chief resident when I came here and was on faculty. And I can tell you these two individuals, incredible individuals, were amazing mentors for me, and the reason I came and the reason I stayed. Just an incredible level of humility, but also a dedication to educating, ensuring that we're educating our trainees to do the best that we can for all of our patients that come here. And that is a way of, again, addressing disparities. So where I am now, you know, from 2007 to 20, I've had wonderful departmental and institutional roles as I've used my career as a medical educator to advocate for diversity and inclusiveness, but also advocacy roles within North Carolina and nationally to advocate on the legislative and policy level for not only practitioners, but also trainees to ensure that we are receiving the skills that we need to really break down the disparities that we're seeing in our communities and understand what those are. Now and today, 2021, I'm excited that this journey has led to me being the Chief Graduate Education Officer and opportunity to be a GME Dean within our school. And now I'm president-elect for our Pediatric Society and chair of a Diversity and Inclusion Committee nationally. And again, my advocacy tool is education. And when I'm able to use education, but also policy management, how that can have a broad impact of ensuring that we are really working at the top of our skill to address disparities and to ensure that we're treating the patients that we're here to serve. And so I know I stand on the shoulders of giants, and thinking of our giants here just at UNC, I owe a lot to them. So this is Dr. Thal Elliott Jr. Dr. Elliott Jr. was the first African-American graduate from our pediatric residency here at UNC Children's Hospital. I learned about him when I was doing a little deep dig into history. He graduated from our program in 1968, and learning more about him and actually learning about those who knew him, realized that he opened the door even for me to become a trainee here at this program. Dr. Suzanne Tropez-Sims is a graduate of UNC and our pediatric residency program, graduated in 1979 and joined our faculty, an amazing leader and advocate. She joined the faculty at Meharry School of Medicine, became a full professor and dean of clinical affiliations. And I consider her a mentor also, as I've gotten to know her nationally. And I would say the way that she's given back, when I was clerkship director and looking for funds to help us improve the diversity in our programs, Dr. Tropez-Sims donated 3 years annually, over $500 every year to fund us to have a diversity visiting clerkship to our residency program. And I can't tell you how huge of an impact that had. The first year she did, we matched over 7 underrepresented trainees into pediatrics program, had never been done. And those trainees have since graduated and are practicing pediatric dermatology in San Diego, pediatric hematology at Hopkins, pediatric child neurology here back at UNC, and has joined the faculty. And we would not have been able to do that if this wonderful alumnus had not donated money for us to support them to come and do visiting rotations here at UNC. Dr. Rupa Redding-Lollinger, a graduate of our Med-Peds program. She was the first African-American trainee who was selected to be chief resident here in pediatrics at UNC. She is an icon with our pediatric sickle cell program and served as the director for more than 30 years before retiring. And she has been such an inspiration that this year we actually named a visiting rotation for those who are underrepresented in medicine after Dr. Redding-Lollinger, and have successfully had more than 20 different applicants from across the country participate in that. And then in our time here currently, Dr. Christian Lawrence, who is a faculty member that just joined us this year. In 2019, Christian was the first African-American man to ever serve as chief resident in our pediatrics program. And while it's unfortunate that it took from 2019 for that to be the first, we are excited that we have been able to recruit him to stay here at Carolina. He was one of the top applicants in the country during his year. This just shows how investment and dedication to our training can actually have a huge impact within our training programs. So this is one of favorite pictures of mine. Why do I do what I do? These are students here at UNC School of Medicine who are in the Student National Medical Association. And back when times when Dr. Elliott Jr. may have been the only Black student here at UNC, this is how an incoming class may look, and even more. And then as a program director, this is why I do this. These are the pediatric and med peds trainees. And when I matched here, I was the only resident of color in my intern class. And look at this class here. They're from all over the country and the world, and they are dedicated to advocating for, to fight against healthcare disparities and to advocate for health equity. And we could not do that without not only the advocacy of our medical educators, without having medical educators in leadership who are diverse, but also in having our graduates of our program and those who we have served giving back and allowing us to create wonderful opportunities so that we can recruit a class who looks like this and changes the world. And so my take-home message, mentorship is vital. I would not be here without it. Leadership and representation matters. All of those points along the way that I had mentorship and people that I saw, it mattered, and it's the reason that I'm here today. And never forget why you do what you do. And that picture of those graduates and those trainees is a constant reminder. And then this is my last picture. This is my extended family, mine and my husband. And we always, in the time before COVID, would get together for Thanksgiving and do a big family picture. And you know, I started with where I come from in Mississippi. And this is, you know, the descendants of that group from those headstones that I showed. And all of us are wearing the shirts of our alma maters, the historically Black colleges and universities that have trained us to be where we are so that we can advocate on behalf of those most needed. Thank you.
Dr. McNeal-Trice, thank you so much. Your story is so powerful, and we are incredibly grateful to you for your continued dedication to our learner group and bringing along this next generation. You will be one of the giants on the shoulders in which they stand, I'm quite certain. So thank you very much. Dr. Corbie-Smith, we'll turn to you next.
Wonderful. Thank you so much, Leslie. I hope you all are able to see my screen. It's just having known Kenya, and now I get to know a little bit more about her. This is wonderful. So I am going to start with a story. See if I can get this tip forward. And some of you all might be familiar with this allegory. Leslie and Allison asked me to talk about sort of why health inequalities. So, and for those of you all that have gone through the racial equity training by the Racial Equity Institute, this will be familiar to you. So last year, this time I was in the mountains of North Carolina, and I was reflecting on this story that I had heard about, you know, all around us we saw lakes, these beautiful lakes of water, incredible lakes, crystal clear. And so just imagine that you're up in the mountains and you have a home on the edge of one of these lakes, and you wake up and walk to the edge of the lake in the morning and you see a fish that's sick and dying on the edge of the lake. You might think, so what's wrong with that fish that it's sick and dying? As you come out of your lake cabin, and each day you notice more and more fish sick and dying. And you begin to think, well, maybe there's something wrong with the lake. Maybe the water isn't, you know, good for these fish. As you start to go through the mountains, you notice lake after lake, you come upon these fish that are sick and dying. Lake after lake after lake. And this is the allegory that the Racial Equity Institute uses to describe the fact that when we look at health inequalities, we think that it's isolated in healthcare, that these disparities that we see are isolated to healthcare. But what we realize is that in every system, persistent and consistent inequalities exist. And these are the lakes These are the lakes in our healthcare system. These are the lakes in our child welfare system, educational, juvenile justice system, special ed, and economic development. And what trips us up is that we have a different term for these health inequalities, these inequalities in every one of these systems. For health, we call it health disparities. In child welfare, disproportionality in terms of children of color. In education, for those of us that have children in the educational system, we hear about the achievement gap and so on and so on. But the reality is that there's a consistent and persistent source of these inequalities, and that's structural racism. When we think about the inequalities that we're seeing, we have to realize that the groundwater, the water that's feeding these lakes, the systems, policies, and practices that lead to these inequalities are the same: structural racism and other forms of systemic oppression. So let's talk about what are health disparities. These are differences in health outcomes between groups that reflect these social inequalities and societal and social identities. There are many axes of inequality that we can look at, and whether it's race, ethnicity, gender, and gender identity, education, income, and so on. But when we start to flip the idea to think about equity, which is the sponsor, one of the sponsors of this convening is around diversity, equity, and inclusion, we realize that we actually need to have a slightly different way of framing this work. Achieving equity requires that not that everybody gets the same treatment. So in this image from the Robert Wood Johnson Foundation, everybody gets the same mode of transportation, regardless of what their needs are. Achieving equity requires that we value all the individuals and populations equally, but we also need to recognize and rectify historical injustices. The incredibly powerful history of Kenya's family that she shared with us is just one of many, many millions of people who have experienced and triumphed over a history, 400 years of a historical context that's rooted in policies, practices, norms that have advantages one group and disadvantages others, based on a fallacy of a hierarchy of human value. And we need to recognize and rectify these historical injustices as we're looking to achieve health equity. It's providing these resources according to the needs of the individuals, and it really requires, and I would suggest, a fundamental shift in how we think about those that are at the margins, those that are experiencing poor health outcomes disproportionately compared to others. And health disparities will be eliminated once we have achieved health equity. And this is an active, ongoing issue. It's not a state that we get to, it's a state that we're constantly striving towards. Many of you all may have heard this term, social determinants of health. These are the range of ways that our environments are constrained or provide the resources for us to experience a healthy life. It's the places and the conditions that people are born, grow, work, live, and age, and this wider set of forces and systems that shape the conditions of daily life, that make it easy or hard for people to have the opportunity to be healthy. These include economic policies, systems, social norms, social policies, and political systems. As a healthcare professional, Kenya, Keisha, and I all grew up in a system that had us focusing downstream, focusing on behaviors, disease, injury. And these are incredibly important, and I would never change the way that I was trained. But what I have come to realize is that we also need to be thinking upstream. If we truly want to address health inequalities, we need to be looking at a much further upstream at where these social inequalities are, how it shapes institutions and the living conditions in which our patients live, grow, work, and pray. So in the midst of this, and there's been such increasing interest in diversity, equity, and inclusion after the events of this last year, it's sobering to me that just in this last couple weeks, we've seen any gains that we've made around equity lost. In 6 months, we've seen overall life expectancy go down by 1 year in the course of 6 months, where COVID-19 and the coronavirus infection has become one of the leading causes of death in this country. And even in that setting, we see that this disparity in years of life lost, from African-American, non-Hispanic, Black men having the greatest decline in years of life expectancy, 3 years, in the course of 6 months, compared to white females who had less than a year of life lost. These inequalities in health are staggering, distressing, and really a call to arms and a call to action for all of us that are doing this work. So I wanted to tell you a little bit about the Center for Health Equity Research and what we're doing and how we're thinking and partnering with communities to address health inequalities. Our mission is to bring together collaborative, multidisciplinary teams of stakeholders, really to focus on improving the health of North Carolina communities. And we share with our community collaborators a commitment to innovation, collaboration, and health equity. Our vision is to create and maintain cross-disciplinary synergy. We believe that any problem as large and complex as health inequalities requires as many disciplines as possible and as many people looking at this elephant from all its vantage points. We seek to advance research methods because what got us here won't get us to there. We need to think about new ways about doing research to be able to get us out of this issue. To think about what we know works and how do we get it out? How do we translate discoveries to improve health to more people more quickly in more places? And really always to conduct research that addresses the patient and community-centered outcomes. What's of value and of interest to the people that we hope to serve with this work? Our values are rooted in collaboration, respect, equity, social justice, innovation, and productivity. The Sutton family actually gave us the initial support to bring on medical students. We are overrun on a regular basis with undergraduate medical students, doctoral students, graduate students, junior faculty who are hoping to do work in this space. And we're so grateful to the support for the Sutton Family Foundation that has been able to fund between 2016 and 2019, 8 medical students to work with us and have this experiential opportunity for current UNC medical students. They, in the summer, complete a mentored independent research study. They participate in research training, professional development activities, and immersion in community activities. And this is just a smattering of some of the images from their projects that they've done over those 3 summers. I want to share with you, though, one other project that we do at the UNC Center for Health Equity Research, and this is called MAPSCORPS. MAPSCORPS is a program that hires youth and actually started at the University of Chicago. Dr. Stacy Lindow started this program. And it was a way to hire youth, high school seniors, juniors and seniors, and pairing them with science-minded college students as mentors. And you've heard the power of mentors. Science-minded students as mentors to map the assets in communities and to use those assets for the good of the community. What we know is that for many communities, there are strengths. We've often focused on what's wrong in communities and what we need to fix, but the reality is there's a lot that's right in our communities in North Carolina, and particularly in our rural minority communities. Over the last 5 years, each year we've mapped these mappers have mapped about 1,800 assets. When we talk about assets, these are built assets, forward-facing buildings, community services organizations, businesses in Edgecombe and Nash County, the city of Rocky Mount. Each year, they map those assets. And what we know is when you map those assets, and using the best available data, about 25 of those community assets are either not in the best available database, Google, Dun & Bradstreet, or they were there, but they're no longer in business. So how can you use the assets that are available if you don't actually know what's there? We've been able to hire 50+ high school student mappers over the course of those 5 years and engage 20 college mentors and research assistants. And this project, in collaboration with community partners in Edgecombe and Nash counties, as well as the University of Chicago, the goal is to expose these students, these incredible youth, to a scientific and research curriculum and data collection, and also provide professional development training. And in terms of community assets, they're given accurate, free, and freely accessible online database of the resources that are available, and we actually provide employment for youth. And I'm going to stop sharing my screen here and ask Allison to bring up a video so you can see these incredible youth in action.
MAPSCORPS is a youth-based asset mapping program. High school students go throughout the community of Rocky Mount collecting data about businesses in the area. And the goal is to collect this information to provide it back to the community so the community can know what's available. At the UNC Center for Health Equity Research, everything that we do there is in conjunction with the community. We really take this approach because we want the community's input into solving some of these challenges.
When we go out, we get to communicate with people, and I'm very social, so I like that. We have fun, we talk to everybody, we enjoy our time. And I like the people here. They very friendly, they make me feel like I'm comfortable, make me feel like family.
So in addition to collecting the data, they also conduct research projects throughout the summer and the afternoons through what we call our positive youth development curriculum.
We provide leadership development, communication training, as well as actually engage them in getting to design their own small research project. And we really encourage them to really think about the data they're collecting and how that can contribute to answering research questions.
I just hope that they can feel invested into the city of Rocky Mount. They want to see growth and change, so I just hope that this project can be used to inspire them to make those changes happen in the future.
I think we can stop now, Allison. That's great. Thank you. And so what we have done is actually use those data and include that into the electronic medical record. Those are the data for almost 20,000 places. And those algorithms are included in the electronic health record. And what's called a community RX is generated for patients based on their health conditions. And those patients then have access to community resources, ready, accurate, available data on the resources that can help them be healthier in their lives. Let me move this forward. And this is just our collaborators across the state and also across the country in this work. And I'm going to just stop there so that you can have our contact information. And I look forward to hearing more from each of you all.
Thank you, Dr. Corbie-Smith. Your investment in communities across North Carolina is just incredibly powerful, and the changes that need to come from the work that you're doing are just very, very, very powerful. So thank you for sharing your remarks. Dr. Gibson, bring us home.
Yes, I'm going to bring us home, and I am going to pay attention to time because I want to be respectful of everyone's time. So much great information today. What I hope to close with is a little bit of sort of bringing some attention to kidney disease and hopefully ending up a little bit with the importance of us supporting our pipelines. So to start this off, I was going to tell a little story about Mrs. Nelson. Now, I don't want you to worry. I am HIPAA compliant. I have changed Miss Nelson's name. But Miss Nelson is an African-American woman who lived in a small rural town in South Carolina. She graduated from high school. She got married. She had 5 children and made a modest living working in food services in a local correctional facility for about 20 years. Fast forward in time, her children grew up. Her husband died. Her parents were aging and fell into failing health. And so she moved in to take care of them as their primary caretaker. Her father, at the age of 87, developed kidney disease, end-stage kidney disease, and required hemodialysis and had to be transported 25 miles to the nearest center in order to get treatment. He actually survived for about 5 years on dialysis before he died at the age of 92. Her mom, at the age of 91, also developed kidney failure, but given all of her other comorbidities, the family decided against dialysis and she soon died. About 2 years after this, Ms. Nelson found out that she herself now also had advanced kidney disease. She had been battling diabetes for about 35 years and was told that in order to survive, she needed dialysis. But her blood vessels weren't healthy enough to connect together to be able to use for dialysis. And so her likelihood of survival was pretty slim. So Ms. Nelson remembered that she actually had a niece who was training to be a nephrologist and got on the phone and called her and said, listen, I've been battling kidney disease for about 10 years and they're telling me I need to start dialysis, but I don't have many options. So I need a little advice. So her niece, who was still in training as a fellow, got in her car and drove 5 miles to South Carolina to accompany her on with her doctor's visit and look at her nephrologist and say, has anybody talked to her about transplant or peritoneal dialysis, which is a form of dialysis that you can do at home and is an option for somebody who doesn't have healthy blood vessels to complete dialysis? And the nephrologist looked at her niece and said, you know, I really hadn't considered her a candidate for that, but you know, maybe that's an option, let's give it a try. And so with her niece's advocacy, Ms. Nelson was able to start peritoneal dialysis, and she actually had a pretty good quality of life for those last 5 years or so that she was here on Earth. Now, I'm sure many of you have guessed, Ms. Nelson is my aunt, and was my aunt, and I was that nephrologist niece. And you know, that story, I think and reflect on that story often because I wonder what would have happened if I hadn't gone to join her for that visit. There are currently 37 million people in the United States right now living with chronic kidney disease, and about 400,000 of them are on dialysis. African Americans in this country make up about 11% of the population, but we represent 30% of the individuals that are on dialysis. So a huge discrepancy. And when you look at that dialysis population, in fact, 60% of people in this country that are on dialysis represent people of color across the gamut. So African Americans, Hispanic, Asians, Island Pacificers. So huge disparity there. So there's a lot of work for us to do in this country. And as I reflect on the situation with my aunt, I couldn't help but to feel or to think that in some ways bias may have played a role. It was not lost on me that my aunt was an African-American woman with a high school education, modest income, living in a rural area, and her physician was an older white male. Now, do I think that this physician wanted my aunt to have a bad outcome? No, absolutely not. Matter of fact, he was a wonderful partner. Once we had that discussion, he was a great doctor for my aunt. But do I think that there were assumptions that he made on the basis of who she was? And the answer to that is yes. And this happens more often than we know. Bias is often unconscious. And the question is, how do we overcome some of the challenges and some of the disparities that we see in healthcare that are related to these innate biases? We have to measure them. We have to become more aware of them. And we have to educate each other because we all harbor them. No matter who you are, every last one of us harbors some kind of bias. And so thinking about who makes up our environment, who makes up healthcare is greatly important. And how do we do that? How do we help bridge the gap for a lot of individuals that have unfortunately had a lack of opportunity due to structural racism? Is we strengthen our pipeline, we build our pipeline, and we support our pipeline. So I'm a very proud product of pipelines. So I was born and raised in Durham, North Carolina. From 6th grade until 12th grade, I was a part of the Math and Science Education Network. And UNC was in fact the sponsor of that program. I think right now, North Carolina State and a few of our other local colleges are supporting it. So every Saturday, I was on a school bus heading to UNC Chapel Hill to engage in enrichment courses in math and science. And so at that early age, they had me as a captive audience. I was able to engage in summer research programs. So I spent 3 summers at the National Institutes of Environmental Health Sciences in a summer research program, 2 summers at an NIH once I went to college. Again, all part of a pipeline program. And then very formative for me was the opportunity to engage in a medical education development program here at UNC, which is a program specifically to help underrepresented students and students that are coming from non-traditional backgrounds, so maybe coming back as a second career, to help prepare you for what medical school will look like. And it was that summer that I think my fate as a nephrologist was sealed, because my pedigree all up until that time was to stay in a lab, which is very important. We need our lab scientists. But that was the summer that helped me understand that, yes, you have what it takes to be a physician, and look at the amount of kidney disease in your family. This is what you can do. So leaving the MED program and applying to medical school, I came into medical school saying, I'm going to be a nephrologist. Said nobody else ever. But the pipeline programs that UNC has supported, and donors like you that are on this call have helped support it, laid that path for me. And so I just really want to put out a plea and a thank you for supporting those programs. You have raised somebody who truly credits having those programs in my life to open up opportunities and provide me now the opportunity to serve in the capacity that I serve with the Department of Medicine, and to serve as mentor for our other students that are coming through our pipeline programs. And with that, I'm going to pass the baton to Leslie so that maybe we can answer a few questions.
Dr. Gibson, thank you so much. Your passion for this space and helping those that are struggling with kidney disease is really just incredibly commendable, and glad that you got to talk a little bit about the pipeline program and our MED program. We'll have to continue that conversation on another talk like this, but we do have a couple of minutes to answer some questions, and you all were thoughtful and sent a lot of questions to us beforehand. But before I'm going to try to answer or get to as many of those as we can, but I did just want to oh, actually, never mind. One of them has already been answered. Dr. Corbie-Smith is on it. Okay. All right. So here we go. Here are some of the questions that were submitted to you all. So do you think that there is a pathway of how people should manage and model microaggressions amongst students, so amongst learner populations? So how can we help with microaggressions? I'll turn that to one of you guys to answer.
I can start with that. And one of the reasons I start is because I'm actually have had a great opportunity to collaborate with some colleagues across the country and develop a workshop that is designed for training how to address and recognize microaggressions in the clinical space. And so, my first statement would be that recognizing what microaggressions are, and training individuals to recognize and to respond. And this is not just leaders in the leadership space, but this is everyone, faculty, our staff, our healthcare and nursing colleagues, our fellow students, knowing how to recognize and advocate for one another. It's incredibly important. I can tell you, especially with regards to microaggressions, there often is a discussion about the intent of what was done or said. And regardless of what the intent was, it does not negate the impact of what occurred. And there are some of us who have certain words or behaviors perpetrated against us over and over again. It's part of our daily existence, regardless of whether that is the intent of the individual. So recognizing that and advocating from that perspective is incredibly important. And it establishes the culture of an institution. So, I've had been saying this a couple of times, but have a really wonderful quote from a book that I'm reading that says, an institution's culture is not determined by its vision or its mission. An institution's culture is determined by the worst behavior that we will tolerate.
Wow.
And so when we recognize that these microaggressions and sometimes macroaggressions exist, and then educate ourselves on how to recognize, but also how to advocate and address them, I think that is incredibly important, not only to create a culture that we work and educate one another, but also to create an environment where we truly are equitable and inclusive for the patients and families that we serve.
Kenya, just her comments are exactly spot on. And the only thing that I would add is, I know some folks might feel uncomfortable in terms of stepping out, in terms of being an ally in that space. And what I would offer in the allyship workshops that we do for the leadership program that I co-lead is remind folks about how that person that's the target feels. It's typically going to be far worse than you're ever going to feel. And it's a skill that you just need to practice.
And I'll just quickly add, I agree with all of those comments. Also really focusing on the act and the behavior itself. I think the more that you can avoid, really sort of, for lack of a better way, attacking the person, but really focusing on the act, that definitely helps people to hear.
So we have a number of questions, and I'm so sorry that we're not going to be able to get to all of them because we're at the top of the hour here. I'm going to just ask one more question, and then hopefully we can close things out here. So what time frame do you see for us achieving health equity? Where are we now, and what steps need to be taken to move forward? Any of you all are welcome to jump in.
Sorry, Leslie, I was trying to see if I could answer any of the questions in the Q&A. Can you repeat your question?
Sure, no problem. What time frame do you see for our achieving health equity? Where do you think we are now, and what steps do you think we need to take to move forward? You answered some of this, Dr. Corbie-Smith, in your presentation, but I think maybe a level set as to where we are right now might be helpful for the group.
I can't say how long it's going to take. This is about will and skill, right? Mm-hmm. So there's got to be the willingness in this country to move beyond diversity statements, which I think have been important and so critical to raise awareness over this last year, to action. And it's going to take folks being willing to be uncomfortable. Because the system that got us here is not the system that's going to get us there. So, and then it's also building the skill set so that folks understand, how do you address microaggressions? How do you change systems? I think that that statement of that, the quote that Kenya offered, that it's what's the worst behavior that we're willing to tolerate? And, I think for UNC Health, what has heartened me is that I'm seeing that people are willing to sort of look at data disaggregated by race and being willing to look at the outcomes. That's the first step. We need to be able and willing to be able to say, we're not where we need to be, and create a plan for us to get there and hold ourselves accountable for doing so.
Yeah, and I think in addition to that, we have to also remember that the challenges that we see in health equity extend well beyond our walls. And so, when we're talking about erasing disparities in health, you can't do that without talking about disparities in economics, without talking about housing insecurity, systems like redlining, without talking about the digital divide and how we fund, public schools. And all of this is all integrated into us combating health equity. And it's going to take time.
Thank you. So we are at the past our time here for tonight. I just want to say thank you all again for joining us. A huge thank you to Dr. McNeal-Trice, Dr. Corbie-Smith, and Dr. Gibson for sharing their remarks and reflections today. And I just want to also say, if you are inspired by what you have heard today and you want to get involved and do more, please let us know. We are happy to talk with you about the fundraising that we are doing for our health equity programs. So if you're interested, again, please let us know. And I think that's all for tonight. Thank you again for joining us, everybody, and have a great evening.
Thank you so much.
Bye-bye, everybody.
Everybody.
Thank you.